Hey there. Today, we are completing the clinical manifestations of liver disease. We're diving deep, pulling from established medical knowledge to give you the essentials. Today, we're zeroing in on three major areas. First, the surprisingly hopeful idea that liver scarring, fibrosis, isn't always permanent, it can actually reverse. Second, what that telltale yellow tinge, jaundice, really signifies about liver or bile duct function. And third, the complex and often dangerous cascade of portal hypertension. These aren't isolated topics, you know. They're all interconnected, pieces of the bigger puzzle in understanding liver disease. Alright, let's jump right into that first one, fibrosis reversal. Because honestly, the idea that scar tissue in the liver can actually go away sounds, well, maybe more optimistic than you might expect. But it really is possible. We're talking about liver fibrosis, that buildup of scar tissue. Current understanding suggests it can actually be reversed, or at least stabilized, in a significant number of patients, maybe even up to 80% with the right treatment targeting the underlying cause. Think about specific conditions where this reversal has been observed, things like iron or copper overload diseases, like hemochromatosis or Wilson's disease, liver damage from alcohol, chronic hepatitis B, C, or D, non-alcoholic fatty liver disease or NASH, secondary biliary cirrhosis, even autoimmune hepatitis. These are concrete examples where tackling the root cause gives real hope for the scar tissue to regress. What's truly amazing is the liver's own inherent ability to regenerate. The whole process of fibrosis resolution hinges on two main cellular events. First, breaking down that tough fibrous scaffolding, the extracellular matrix or ECM, that's the scar tissue itself. And second, reducing the survival of the very cells that build the scar tissue, primarily the myofibroblasts. Think of them as the scar builders. So, it's like the body is simultaneously dismantling the existing scar and telling the builders to stop building and clear out. Exactly. But, you know, it's a regulated process. There are molecules called TIMPs, tissue inhibitors of metalloproteinases. During active injury, these TIMPs can actually put the brakes on ECM breakdown, essentially protecting the scar, and they also help those scar-building myofibroblasts survive longer. So, in chronic injury, TIMPs can kind of work against the reversal process, making the scar persist. On the flip side, you have other signals that push those myofibroblasts towards apoptosis, programmed cell death, or encourage the immune system to clear them out. Interestingly, proteins called P21 and P16 also seem to act like brakes on the scarring process itself, encouraging the myofibroblasts to enter a state of senescence, like cellular retirement. So, the body has mechanisms both for breakdown and for stopping the building process. Okay, let's shift gears to something more visible, jaundice. That yellowing of the skin and, especially, the eyes. Jaundice is often called the most specific clinical sign pointing towards a liver or bile duct problem. But here's a crucial caveat: its absence doesn't rule out liver disease, especially chronic liver disease. And you can also get jaundice simply from producing too much bilirubin, like in cases of significant hemolysis, where red blood cells are breaking down rapidly. That's a really key point. Jaundice strongly suggests a liver or biliary issue, but no yellow doesn't mean no problem. It all comes down to bilirubin, that yellow pigment, building up in the blood and getting deposited in tissues, skin, mucous membranes, and particularly the sclera, the whites of the eyes. Why the eyes? It's mainly the contrast. That bright white background just makes any yellow discoloration really stand out. Clinically, jaundice usually becomes apparent when total serum bilirubin levels hit about 2 to 3 mg per deciliter. Though, an interesting practical point, it might take higher levels to spot it easily under fluorescent lighting. Kind of tricky. Now, here's a really neat clinical correlation: jaundice, stool color, and urine color. If bilirubin isn't getting cleared into the gut properly, maybe due to hepatitis or a blocked bile duct, cholestasis, the stool can become pale, gray, sometimes called echolic. Why? Because bilirubin metabolites, like stercobilin, normally give stool its brown color. No bilirubin getting into the gut means no brown color. And the flip side? If you have increased conjugated bilirubin in the blood, that's the water-soluble form, the kidneys can filter it out. This excess bilirubin ends up in the urine, making it look dark, often described as orange-brown or tea-colored. So, seeing pale stools and dark urine together? That's a strong clue pointing towards cholestasis, a problem with bilirubin clearance into the bile ducts. Of course, jaundice can also arise from inherited problems with bilirubin metabolism itself, like Gilbert's or Crigler-Najjar syndromes, but that's a whole other deep dive. Alright, let's tackle the big one, portal hypertension. Sounds a bit like plumbing problems in the abdomen, and that's actually a decent way to think about it. The portal circulation is this vital network that drains blood from the gut, the spleen, the pancreas, and the gallbladder, all flowing into the liver via the portal vein. This vein itself is formed where the splenic and superior mesenteric veins join up. Normally, the blood flow here is quite high, 1,000 to 1,200 milliliters per minute, but the pressure is kept low, only about 5 to 7 millimeters of mercury. Portal hypertension is simply when the pressure in this portal system gets too high, usually because of some kind of blockage to flow. These blockages get classified based on where they occur relative to the liver's tiny blood channels, the sinusoids. You have presinosoidal, blockage before the sinusoids. Think of a clot in the portal vein itself, portal vein thrombosis, or the parasitic infection schistosomiasis scarring the small portal venules. Interestingly, conditions that just massively increase blood flow into the portal vein can also cause presinosoidal hypertension by overwhelming the system. Felty syndrome, rheumatoid arthritis, big spleen, low white cells, is an example of this high inflow type. Sinusoidal, blockage within the liver sinusoids. By far, the most common cause here is cirrhosis. That widespread scarring just completely disrupts the liver's architecture and obstructs blood flow through the tissue. But it can also happen, sometimes temporarily, with severe acute or chronic hepatitis, or acute fatty liver of pregnancy. Basically, any significant inflammation or disruption within the liver tissue itself can impede flow. Postsinusoidal, blockage after the blood has passed through the sinusoids. The main cause here is hepatic vein occlusion, often called Budd-Chiari syndrome, usually due to clots blocking the veins draining the liver. This is often linked to underlying clotting disorders and can be a real emergency, causing rapid liver swelling, severe pain, massive fluid buildup, ascites, and maybe mild jaundice. Chronic heart failure can also cause it. If the heart isn't pumping effectively, blood backs up into the liver, causing congestion and raising pressure, that backup effect. Rarer causes include things like liver abscesses, membranes blocking the inferior vena cava, or veno-occlusive disease, sometimes seen after bone marrow transplants. Lots of potential roadblocks on the way out. But it's not just about physical blockages like scars or clots. There are also dynamic factors at play. Contraction of certain cells within the liver, like hepatic stellate cells and myofibroblasts, can actually squeeze down on the small vessels. Plus, various vasoactive substances circulating in the blood can also cause constriction within the liver. These dynamic factors can contribute to sudden spikes in portal pressure, which is often what triggers dangerous complications like bleeding from varices. Paradoxically, while resistance is high inside the liver's portal system, blood vessels often dilate elsewhere in the body, particularly in the splanchnic circulation, the vessels supplying the gut. This vasodilation actually increases the volume of blood flowing into the already high-pressure portal system. It becomes a complex, vicious cycle. So, how does the body try to cope? It creates detours, portosystemic shunts or collateral vessels. These are new pathways that try to bypass the high-pressure zone in the liver, allowing blood to flow directly from the portal system back into the systemic circulation. Initially, these might not cause symptoms, but as portal pressure climbs higher, more and more blood gets diverted away from the liver. And bypassing the liver means bypassing its crucial functions. This leads to a whole host of clinical consequences. Hormonal changes. The liver normally metabolizes hormones like estrogen. When blood bypasses it, you can get an altered estrogen to testosterone ratio. This leads to visible signs like spider angiomas, those little spiderweb blood vessels on the skin, palmar erythema, red palms, gynecomastia, breast enlargement in men, and menstrual irregularities in women. Impaired detoxification, waste products normally cleared by the liver, like ammonia produced by gut bacteria from protein, build up in the blood because they're shunted away from the liver. This leads directly to hepatic encephalopathy, that spectrum of confusion, altered mental state, and neurological problems. The brain gets exposed to toxins the liver would normally filter out. Reduced synthetic function, most nutrients absorbed from the gut go straight to the liver via the portal vein. If that blood flow is reduced or shunted, the liver's ability to synthesize protein suffers. You see low albumin levels, hypoalbuminemia, which contributes to fluid leaking out of vessels, causing edema and ascites. Production of clotting factors also decreases, leading to a higher risk of bleeding, coagulopathy. Paradoxically, production of anti-clotting factors like antithrombin 3 can also decrease, which might actually increase the risk of clots forming elsewhere in the body. It truly hits everything: synthesis, detoxification, hormones. But perhaps the most acutely dangerous consequence of these shunts developing are varices. These are enlarged, fragile veins that form, most commonly, in the esophagus, but also in the stomach or rectum. Esophageal varices are the big worry because they can rupture and cause massive, life-threatening bleeding, hematemesis, vomiting blood. This is a leading cause of death and hospitalization in people with cirrhosis. The stats are pretty stark. About 40% of people might already have varices when they're first diagnosed with cirrhosis, and around 6% develop them each year after diagnosis. Normal portal pressure is low, maybe 1 to 5 mm of mercury. Shunts start opening up above 10 mm of mercury, and the risk of variceal bleeding really climbs when the pressure gradient exceeds 12 mm of mercury. If varices rupture, it's a true medical emergency. Treatment aims either to get rid of the varices directly, often using endoscopic banding, where tiny rubber bands are placed around the base of the varix to cut off its blood supply, or to lower the portal pressure. Medications like non-selective beta blockers are standard for lowering pressure by reducing portal inflow. And then there's the TIPS procedure, transjugular intrahepatic portosystemic shunt. This is more invasive. A stent is placed right through the liver tissue, creating a direct channel between a branch of the portal vein and a hepatic vein. It effectively bypasses the congested liver, lowers portal pressure significantly, reduces bleeding risk, and can help with fluid buildup like ascites. But there's always a but, right? Because you're deliberately shunting more blood away from the functional liver cells, TIPS can worsen or even precipitate hepatic encephalopathy. It's a crucial trade-off to consider. Okay, let's talk more about that fluid buildup, ascites. That accumulation of fluid in the abdominal cavity, causing the belly to swell. Ascites is the most common clinical finding in portal hypertension. While maybe not as immediately life-threatening as a variceal bleed, it causes significant discomfort, can make breathing difficult by pushing up on the diaphragm, and, importantly, it creates an environment where a nasty infection called spontaneous bacterial peritonitis, SBP, can develop. But how does ascites actually form? It's complicated, with multiple factors playing a role. You've got the high hydrostatic pressure in the portal veins literally pushing fluid out. You have the increased resistance within the liver sinusoids. You often have low serum albumin, meaning less oncotic pressure holding fluid inside the blood vessels. And there might even be some direct leakage of protein-rich fluid, lymph, from the surface of the congested liver. However, the likely primary event triggering significant ascites is probably that peripheral arterial vasodilation we talked about, the widening of blood vessels outside the portal system. How does that lead to fluid in the belly? Well, that widespread vasodilation makes the body think the effective circulating blood volume is low. The kidneys react by kicking the renin-angiotensin-aldosterone system into high gear, desperately trying to hold on to sodium and water to boost the volume. But, because of the high pressure in the portal system and the low albumin, that extra retained fluid doesn't stay in the blood vessels, it leaks out into the abdominal cavity, the third space. It's like the body's compensatory response actually makes the ascites worse. So, when someone presents with new ascites, it's crucial to figure out why. Is it due to portal hypertension, or could it be something else like cancer, infection, or heart failure? The key test is analyzing the acidic fluid itself, specifically calculating the serum ascites albumin gradient, or SAG. You compare the albumin level in the blood serum to the level in the acidic fluid. If the difference is significant, specifically, if the serum albumin is more than 1.1 grams per deciliter higher than the ascites albumin, SAG greater than 1.1, it strongly points towards portal hypertension as the underlying cause. Though, a high SAG can sometimes also be seen in heart failure. How do you manage ascites related to portal hypertension? The cornerstone is achieving a negative sodium balance. This means a strict low-sodium diet, often harder than it sounds, and diuretics, or water pills. Because that renin-aldosterone system is overactive in cirrhosis, you usually need drugs that block aldosterone's effect, like spironolactone, often combined with a loop diuretic like furosemide to effectively get rid of the excess sodium and water. If diuretics aren't enough, or if someone needs quicker relief from massive ascites, the procedure is paracentesis, draining the fluid out with a needle and catheter. You can remove several liters this way. However, if you take off a large volume, say more than 4 or 5 liters at once, it's standard practice to give intravenous albumin afterwards. Why? To prevent something called post-paracentesis circulatory dysfunction, basically, a rapid drop in the effective blood volume that can shock the system and severely damage the kidneys. The infused albumin helps to keep fluid within the blood vessels. Now, back to that infection risk, spontaneous bacterial peritonitis, SBP. This is an infection of the acidic fluid itself, but without an obvious source like a hole in the bowel. It's thought to happen when gut bacteria, usually gram-negatives like E. coli, somehow translocate across the intestinal wall and seed the fluid. How does SBP show up? It can be subtle, but common signs include new or worsening abdominal pain or tenderness, maybe worsening ascites, fever, chills, or just feeling generally unwell. Sometimes the only sign might be a worsening of liver function or an unexplained episode of hepatic encephalopathy. You might see an elevated white blood cell count in the blood, but not always. Diagnosis relies on tapping the fluid again, a diagnostic paracentesis, and analyzing the cell count. The key finding is an elevated neutrophil count in the acidic fluid. The usual cutoff is an absolute neutrophil count of more than 250 cells per microliter. This is diagnostic of SBP, even if the bacterial culture of the fluid comes back negative, which happens in up to 60% of cases. So, if the neutrophil count is high and you clinically suspect SBP, you treat immediately with broad-spectrum antibiotics, don't wait for the culture results. And those bedside dipsticks sometimes used to check for white cells in fluid. Medical sources generally say they aren't reliable enough for diagnosing SBP due to too many false negatives. Okay, let's circle back to hepatic encephalopathy, HE. We touched on it as a consequence of shunting, but it deserves a closer look because it's such a major complication. He represents a whole spectrum of neuropsychiatric problems, essentially brain dysfunction, caused by liver failure or the portosystemic shunting of blood away from the liver. It can be acute or chronic. And importantly, lots of things can trigger or worsen an episode of HE in someone with underlying liver disease. Think dehydration, electrolyte imbalances, especially low potassium, infections, like SBP or UTIs, constipation, eating a large protein meal, any kind of bleeding, especially GI bleeding, which puts a big protein load in the gut, kidney problems, low oxygen levels, the TIPS procedure itself, surgery, and certain medications, especially sedatives like benzodiazepines, which the failing liver can't clear properly, and the brain might be extra sensitive to. The symptoms range incredibly widely. It can be very mild, maybe just disturbed sleep patterns, some irritability, subtle personality changes, or difficulty concentrating, sometimes called minimal He. Or it can be much more obvious: confusion, disorientation, slurred speech, drowsiness, personality changes, and that classic flapping tremor of the outstretched hands called hysterexis. You might also see increased muscle tone or problems with gait and coordination. In severe cases, it progresses to stupor and deep coma. In chronic liver disease, He often fluctuates. In acute liver failure, however, it can progress terrifyingly fast, sometimes accompanied by dangerous brain swelling, cerebral edema. What causes it? Well, it's complex and not fully understood, but ammonia definitely plays a big role, especially in acute He. Ammonia is neurotoxic and normally cleared efficiently by the liver. When the liver fails or blood is shunted, ammonia levels rise. However, it's important to know that ammonia levels don't always correlate perfectly with the severity of chronic He. This suggests other factors are involved, likely a combination of other toxins that aren't cleared, systemic inflammation, and alterations in neurotransmitter systems within the brain, possibly involving the GABA system or even endogenous benzodiazepine-like substances. So, how do you diagnose He, especially the chronic form? It's largely a clinical diagnosis, based on recognizing the characteristic signs and symptoms in the context of known liver disease or significant portosystemic shunting. What about checking blood ammonia levels? They are not routinely recommended for diagnosing or monitoring chronic He. While a normal level might help rule it out if the clinical picture is confusing, high levels aren't required for the diagnosis, and levels don't track well with severity. Ammonia levels can be more useful in the setting of acute liver failure or acute He to help pinpoint a hepatic cause for altered mental status. Other tests. An electroencephalogram, EEG, can sometimes be helpful. It often shows characteristic slowing of brain waves, sometimes with specific patterns like triphasic waves, although these aren't entirely specific to He. Treatment for He primarily focuses on reducing the amount of nitrogenous waste produced in the gut, as gut bacteria generate ammonia from dietary protein and urea. Lactulose is a mainstay. How does it work? It's a non-absorbable sugar that gets fermented by gut bacteria, which acidifies the colon. This acidic environment traps ammonia as ammonium ion, NH4+, which is poorly absorbed, and promotes its excretion. Lactulose also acts as an osmotic laxative, helping to clear out the gut contents. Non-absorbable antibiotics like rifaximin are also commonly used, often in combination with lactulose. Rifaximin works by reducing the population of ammonia-producing bacteria in the gut. For those very severe acute cases with brain swelling, that's an ICU situation requiring measures to reduce intracranial pressure, possibly using osmotic diuretics like mannitol. Next up, another serious complication, hepatorenal syndrome, HRS. This is essentially kidney failure that occurs as a direct consequence of severe liver disease. HRS is defined as decreased kidney function occurring secondary to advanced liver disease, usually in the setting of cirrhosis and portal hypertension, though it can also happen in acute liver failure. There are generally considered two types. Type 2 hours. This is more common and represents a slower, more gradual decline in kidney function over weeks to months. It's thought to be mainly due to that intense renal vasoconstriction driven by the systemic vasodilation we discussed earlier. Type 1 hours. This is the classic, rapidly progressive form, often defined as a doubling of serum creatinine to above 2.5 mg per deciliter or a 50% reduction in creatinine clearance in less than 2 weeks. It frequently happens in someone who already has underlying type 2 hours and is often triggered by an acute event that further drops effective blood pressure, like SBP or a variceal bleed. Type 1 hours carries a very poor prognosis if untreated. What's happening physiologically in both types? The kidneys themselves are usually structurally normal, but they are clamping down hard on their blood vessels, intense renal vasoconstriction. They're doing this because the body, due to that systemic vasodilation, perceives itself as being severely volume depleted, even if the patient has massive ascites. This triggers maximal activation of the renin-angiotensin-aldosterone system and the sympathetic nervous system, leading to extreme sodium and water retention. Diagnosing HRS can be tricky because the usual kidney function tests aren't always reliable in advanced liver disease. Creatinine production might be decreased due to reduced muscle mass, common in cirrhosis, and possibly impaired hepatic conversion of creatine to creatinine. So, serum creatinine might underestimate the true degree of kidney injury. Creatinine clearance measurements are also often inaccurate. Some research suggests that other markers, like cystatin C, might correlate better with the actual glomerular filtration rate, GFR, in these patients, but it's not yet widely used for this purpose. Therefore, HRS diagnosis relies heavily on meeting specific criteria. These generally include presence of cirrhosis with ascites, serum creatinine above a certain threshold, often greater than 1.5 mg per deciliter. No improvement in creatinine after at least 2 days of diuretic withdrawal and volume expansion with albumin. This is crucial to rule out simple prerenal azotemia from dehydration. Absence of shock. No recent use of nephrotoxic drugs. No evidence of intrinsic kidney disease, like protein or blood in the urine, or abnormal renal ultrasound. Ruling out other causes of kidney injury, especially simple volume depletion, is absolutely key. Treatment for established HRS focuses on reversing that intense renal vasoconstriction and expanding the intravascular volume. This typically involves using vasoconstrictor drugs, terlipressin, a vasopressin analog, commonly used outside the US, or sometimes a combination of octreotide plus midodrine, always given together with intravenous albumin infusions. Studies have shown that albumin can reduce the incidence of HRS, for example, when given prophylactically after an episode of SBP, and improve survival in patients with HRS when combined with vasoconstrictors. Can TIPS help? Sometimes. By reducing portal pressure, TIPS can improve renal blood flow and potentially reverse HRS in some patients. However, again, the significant risk of worsening hepatic encephalopathy often limits its use, especially in patients who are already sick enough to have HRS.